will make a start. Meanwhile, a very warm welcome to participants who have arrived so far. We're looking forward to sharing with you lots of information about the Friendship Bench, one of the well-known models in community mental health. And we're looking forward, hopefully, to Vincent Munjune joining us. He will be talking about strong minds and the model there. So that's good. I can see that the participants are coming in fast. They've just had their break, so maybe they were doing some meditation, or maybe they were grabbing a cup of coffee. Let's make a start. It gives me huge pleasure to welcome you, Zvikomborero, and you, Tandiwe, both from the Friendship Bench. It's lovely to have you with us. Tandiwe, why don't you just introduce yourself, and then I'll come to you, Zico.
All right. Thank you so much, Chris. Hi, everyone. It's good to have you on the call. My name is Tandiwe Mashunye, and I'm a medical doctor with a background in public health, majoring in health system strengthening, biostatistics, and epidemiology. So in the past 10 years, I've had an experience of managing large-scale programs like the HIV program, and I've been involved in implementing other programs like the maternal health program. And in all these programs, in terms of mental health, I've been focusing on how we can integrate mental health services within those large-scale programs. Currently, I'm at Friendship Bench, and I'm the head of programs, and we are responsible for scaling up the Friendship Bench model at a national level and also globally. Yeah, that's me.
That's you.
Yes.
I was going to say that's quite enough, and then I realized that would have been very rude.
All right.
But it's a great start. Thank you very much.
Thank you.
Yeah, Zico Morero, give us your own background, if you would be so kind.
Sure. Thank you so much, Chris. And thank you, Glasswing, for the invitation for myself and Tandy and Friendship Bench to participate on this panel. I'm Zvikomborero, working with the Friendship Bench as the development manager. So I'm supporting the organization around resource development and fundraising. My background is in the same field. I've worked for various organizations, supporting various organizations with their fundraising, primarily working in South Africa, working with the Catholic Welfare and Development, Edikamva Youth, one of the largest young people's organizations in South Africa. So I've recently transitioned to Zimbabwe, Harare, my home, and supporting the Friendship Bench. Thank you.
Thank you very much. And you're both most welcome. And we're looking forward to hearing more about the Friendship Bench model. And I must say, Zvico, you had a wonderful background in fundraising. Fundraisers fundraisers are not easy to find. So so it's fantastic that you've got that experience, which is very unusual to have such a lot of experience in the same field like that. So anyway, most welcome, both of you. Now, would you like to make a start with would you like to make a start with the presentation on the Friendship Bench? Would that be good? I think that would be. Yeah,
that would be fantastic, Chris. Let me just share my screen.
Sure.
Participants.
Yeah, I think the technicians will allow you to do that. There we go.
All right.
Yeah. So looking forward to it. Do please give your presentation, and then we'll have a discussion afterwards.
All right. Thank you so much, Chris, for the opportunity. I think just to start us off, we're living in a world whereby the need for mental health services is more apparent. Look at depression is one of the leading causes of disability worldwide, and suicidal cases among those aged between 15 and 24, suicide is the leading cause of death. And we've gone through the COVID-19 pandemic as well. And the World Health Organization estimates that the pandemic triggered a 25% increase in the prevalence of anxiety and depression. So really, there is a need out there for mental health services. But then if we look at the professionals that are there to offer these services, we estimate that like among 1.5 million of people in need, there's just one mental health professional. So our theme right now is scalable models in community mental health. And for me, this speaks about providing services, bringing services closer to the people who are in need, to the community, like bringing the services within their ecosystem where they reside. And that's what we are in terms of Friendship Bench. It's about affordable, sustainable, context-specific models. So who are we as Friendship Bench? We started in 2006 in Mbare. So Mbare is a high density suburb in Harare. Harare is our capital city, Zimbabwe. And really it was through our founder, our visionary, Prof. Dickson Chibanda. So Prof. Dickson Chibanda was working in Mbare, and during that time, there was a lot of political turmoil, and he noticed that there were a lot of people coming to the facilities with mental health issues, medical issues, and the health workers at those facilities were really overwhelmed. So there was a gap in terms of a shortage of staff to offer services, and the need was high. So he decided to rope in community health workers, whom we affectionately call our grandmothers. And as you can see on the picture, that's an example of one of our grandmothers. So what he did is he took these grandmothers through simple talk therapy so that they are empowered to assess for risk for mild common mental health disorders like depression and anxiety. Then if they assess the risk for those at risk, they are able now to offer what we call problem-solving therapy. So you find that maybe the participants are asking, why grandmothers? So our grandmothers are respectable people within the communities. They are pillars within the communities. They are people who are always there, they are always present. And we identified that this is a really strong factor for a person like that to be there in the community and be available to listen to different people and take those people through stages to address different problems that they are facing. So we realized that through this task shifting approach now, because now we're saying that these services were being offered by nurses. Now these services are being offered by community health workers, our grandmothers. That means that now there are a lot of people who can offer services, and also the task shifting approach really provided an affordable, a sustainable solution for our beneficiaries who wanted mental health care services. Then, yeah, so in terms of our services, so our mission as Friendship Bench is to get people out of depression. And we are into creating safe spaces within the community. We are into creating that sense of belonging within our communities. And first of all, we train our grandmothers through an 8-day training of PST. And like I said earlier, they are then able to do a risk assessment of common mental health disorders and offer PST. And we really use unconventional methods. Our grandmothers take these clients and they sit by a wooden park bench. And during those sessions, they go through all the stages of PST until that beneficiary, that client is empowered to come up with solutions on their own to address whatever problems they are facing. And it's not just about park benches, but also it can be under the tree, it can be an office space, it can be behind the wall, whatever the definition of a safe space for that beneficiary is, that's what we do. Then other services like sensitization, awareness are just to support increasing the number of people who benefit from the services that our grandmothers provide. We also have our youth program. So this was just birthed in 2019 when we realized that those aged between 15 and 24 were less likely to access services from our older grandmothers. So we created a buddy system whereby bodies between the same age, they are also able to offer PST services, and this really grounded our online services. So we also offer our PST online, and this was key, like in the COVID-19 pandemic, whereby we were able to reach a lot of people on the online platform, and it strengthened our body system, whereby they were also able to gain experience in terms of offering the different kinds of services. So yeah, so when we talk about scale up, which is our theme right now, as Friendship Bench, our vision is to get a friendship bench within a walkable distance for all. And really that vision talks about scale up. And one of our core values is evidence. So evidence is our main base for everything that we do. It builds a strong foundation for us to map up strategies, for us to go forward. So when we started in 2006 in Bari at 3 clinics, we continued to implement, and then we saw that this model is effective, but we needed a proof of concept, so that at least we now start thinking about scaling up. So between 2012 and 2015, we did a randomized control trial, whereby the intervention was our grandmothers offering PST. And then the control was the normal standard of care, whereby the nurses were offering services. And we found that those in the intervention group, their risk assessment scores were much lower than those in the control group. And also those in the intervention group, their symptoms of depression and anxiety also improved. So now we're armed with this proof of concept, and we had proved that yeah, this model works and this model is efficient and effective. And this was now our basis to say, now we're going to start thinking about scaling up. So you find that from this research, there were a lot of research projects that were birthed from this research in different parts of the country in Zimbabwe. And we managed to leverage on those research projects to start spreading Friendship Bench model across our country, Zimbabwe. So you find that in 2016, we moved to all clinics in Harare, where we started, and also moved to other provinces, Midlands and Masvingo as well. So as we, like what I said, evidence is really key in the things that we do. As we progress in our implementation research, we realize that there are other different components that we can add within the program. For example, the rural component. We realize that implementing Friendship Bench in the rural context versus an urban context is totally different. In the rural context, we have poor networks, and the road networks are also poor, and even the social fabric, the social context is different. So we came to a realization that no, we need to tailor make our program so that we cater to the rural population. And this speaks to scaling up models and reaching everyone who is in need, giving an opportunity for everyone to be able to access mental health services where they reside within their ecosystem. Earlier on, I talked about the Youth Friendship Bench. So it was another model that was also added within our scale-up strategy. So yeah, so we continued to grow as Friendship Bench, and from 2021, we realized that we can take this model to a national scale, to a global scale. And we revised our way of thinking, and we came up with a 5-year strategic plan that will enable us to reach 2 million beneficiaries by 2025. So we used the hub and spoke method, whereby our hub was now Harare, the capital city, and Zimbabwe is divided into 10 provinces. So initially we moved into the 6 provinces, and then this year, 2023, we added 4 other provinces. So now we have a footprint in all the 10 provinces. And yeah, so capacitating others to be dual at scale. So another scale up strategy that we have is supporting in other NGOs and corporate implementers. So in terms of implementation partners, we are partnering with organizations like the World Health Organization, OFID, Pangea, a lot of organizations really. And most of these organizations focus on large-scale HIV programming. So it speaks about integration of mental health into this large-scale program. And what we do is we either capacitate our workers to provide PST services, friendship bench model services, or we actually provide the services to them. And the other way we also scale up is through corporates like banks and other companies, whereby we focus on their mental well-being in terms of their policies. And internationally also we are partnering with other NGOs like in Zanzibar, Malawi, and Vietnam. So really this is how we have managed to scale up our community model. And like I said earlier, this is more about bringing the services closer to where people are, making it affordable, making it accessible, being evidence-based, being relevant also, and also being context specific. So impact up to date, if you can see from the table, in terms of the beneficiaries, we've managed to double that number from 50,000 to about 116,000 people. And the total number of grandmothers that we trained by 2022 was 1,290, and we envision that by end of 2023 we would have had 2,304 grandmothers. And and our CKT groups. So what we have, like when the grandmothers finish like the one-on-one session therapy, they have an opportunity to join a peer-led support group, which is called a Seko Kubatana group, right? And this speaks into togetherness. It's a continuation of therapy, and they also have an opportunity to do economic activities, because we have found out that one of the main reasons why people come to us are due to economic challenges. So we have provided that platform for them to continue therapy. And so far we have 400 groups with 3,147 beneficiaries. Then in terms of impact, we've managed to reduce depression symptoms by 88% and improve quality of life by 60%. And this is data from 2022. So just to wrap us off, I think this is one of the key slides for me. What are the learnings? What can we take from the friendship bench model? And how can we assist others also to scale up their strategy? So like I said, the first thing is evidence. Evidence is very important in whatever you're going to do. If you are planning to scale up, whether it's a community-based model or whatever model that you have. So you need to be informed by evidence, and that lays a strong foundation, a strong basis. And the model has to be sustainable. So low cost approach, scalable and adaptable. Adaptability to context, we talked about the rural versus the urban. For us, that was adapting to context, to say now we're shifting to implementing in the urban areas. So how can we also implement this model in the rural area, and how is the context there different? Even for the youth friendship bench, how is the context different for the youth, and how can we inform the program to adapt to the context? And this task shifting approach is affordable and sustainable, and bridging the mental health gap, treatment gap, and accessibility. I think for me, that's one of the key issues. If we're saying it's community-based, that means it has to be accessible to those who are in need, accessible to everyone. And like I said, our vision as Friendship Bench is to have Friendship Bench within a walkable distance. That talks about accessibility. And one of the key things that we have realized for our model to be a success is partnership with the government. So this speaks to partnership with the Ministry of Health and Ministry of Local Government to gain political will, because these are the gatekeepers within the communities that we operate. So we have leveraged on those partnerships, and we talk about integration into whatever they are doing, co-creation. And yeah, strategic partnerships are also just talking about these key partnerships that we have. And this includes funders and implementation partners as well. So yeah, so this is who we are about as Friendship Bench and how we have gone about scaling up our services, making sure that our services are adaptable, they are available to our community, not only in Zimbabwe, but also at a global scale. So yeah, thank you so much, everyone. And thank you, Chris.
Thank you, Thandiwe. That was very, very interesting indeed. One of our questioners has asked us whether how they can get information about the nuts and bolts, as they call it, on the Friendship Bench, and is the information available in Spanish? They want to know.
Oh, that's wonderful. I think I'll leave it to Shiko. Shiko, you can take this one.
Okay.
Yes.
So,
the question is, yes, please go ahead, Chris, and ask again.
Yeah, please, if you would answer that question, and then I'm going to bring make any other comments you'd like to make on the Friendship Bench, and then I'd like to bring Vincent in so he can have his presentation. So
sure.
Yeah.
Yes, in terms of language, what we have done is, as Thandi was saying, we have taken our work globally and we've worked in different contexts and adapted our model to suit the local language, to suit the local languages. So we have a process as we get into a new country around the theory of change, which kind of places the Friendship Bench within context, trying to understand how the model will work within your context, because maybe it's not necessarily grandmothers, it's probably other people. But then also to define language around depression, anxiety, because in Zimbabwe, our grandmothers defined depression in the local language, Ufungisisa, which could be translated in whatever language where you are at. So absolutely, that's one of the key strategies as well as we scale to understand how can Friendship Bench fit within different contexts as we get out of like English speaking countries or out of Zimbabwe. Yeah.
Okay, so Catherine Mwanga, thank you, Zico. And just one more question for you. Catherine Mwanga says, how long is the training of these grandmothers? Do you train them in local language? And then she asks a very relevant question for me. She says, how about grandfathers?
Yes.
And since I have 6 grandchildren, I think this is highly
all right. No, those are very like key questions. So yeah, so we have a 9-day training. There are physical sessions and also online sessions. So it can either be a 9-day physical training or a hybrid session, whereby there are 3 days whereby we have physical sessions and also online sessions. And yeah, so we take them through all the stages of problem-solving therapy and how to provide these services to our beneficiaries. And yes, we have grandfathers. So we have grandmothers and grandfathers. And yeah, and that question is very important in terms of being context specific, because some people prefer to talk to grandfathers instead of grandmothers. So definitely we have grandfathers.
Okay, that's great. Thank you very much, Thandiwe. Thank you so much, Zico. Vincent, please feel welcome. And I'm sorry that we had a little problem in getting you in at the beginning, but it's lovely that you have joined us now and that you are with us. So Vincent, why don't you just, first of all, before we invite you to make your presentation, maybe Thandiwe, you could take the presentation down when you, if you can. So Vincent, why don't you just introduce yourself, just so that everybody knows who you are. Otherwise, I can introduce you, but I will take longer than you, I'm sure.
Thank you very much, Chris. Thank you for making me welcome. Apologies for the glitches with the technology that happened before, but I'm really excited and glad to be here. My name is Vincent Mujune. I work for an organization called Strong Minds. And Strong Minds is a mental health charity that is working to end depression in Africa using group talk therapy. My background is really public health in nature. I come from a public health background, and over the last 20 years of my work, I can attribute probably about 12 of them just dedicated to the field of mental health, aside from a lot of the other work that I've been doing in maternal and child health, and also in health system strengthening, particularly in Uganda and other countries within Africa. And I'm really privileged to be here to share this platform with Chris Underhill, one of my former leaders when I was at Basic Needs. And so I'm so elated to be in this space. Thank you.
The pleasure is entirely mine, Vincent. I was very, very pleased to see when you were going to come on. That was great news. So, Vincent, do you have a presentation? Do you want us to ask the technicians to show it from this end, or would you like to show it from yours?
I am able to show it from my end if you can see my screen.
Yeah, if you just make it a bit bigger, that is great. Yeah, that's perfect. Well done. Yeah, thank you very much. Over to you.
Thank you very much. So my presentation is going to be quite quick, and my focus is really sharing with you the story that Strong Minds has had around scaling the treatment of depression using group talk therapy as a model that we have championed and taken beyond Uganda, now to a couple of countries around Africa. And we are also testing it out in the United States of America. My name is Vincent, and I am the acting country director for Strong Minds Uganda. Here's my presentation. So a quick brief about us, just to get everyone on board. Strong Minds is a social enterprise that treats depression among women and adolescents in sub-Saharan Africa. We were born way back in 2013. And from that time up to now, we have been on a learning curve, learning how to make IPT better, or interpersonal psychotherapy for groups better, through the stages and the steps we've taken. We are headquartered in Kampala, so our headquarter is not in the United States of America, but we are based in Kampala, and we have a coordination office in the United States of America, but we have another office in Zambia where our teams are implementing the model. Since 2013, when we started, we have been able to treat about 230,000 individuals or sufferers of depression, really focusing on to how much we are able to treat depression and reduce the symptoms of the person that is suffering from depression. We have about 16,000 adolescents that we've treated through this effort to this date. We are also probably the only organization that is scaling a simple and cost-effective solution to depression in Africa. And we pride ourselves in the fact that we are scaling a model that we feel is scalable and is one that we can learn across board. So when we speak about depression, it's always difficult for the person listening to contextualize what it is that we are talking about. And the strongest position we talk about depression is in the symptoms that make depression what it is. So the cardinal symptoms of depression always will stand out. One being that one has an extreme feeling of sadness, emptiness, and hopelessness. But the other strong and cardinal symptom for depression is the loss of interest or pleasure in the things that somebody used to enjoy to do. And then the other symptoms like anger, having angry bursts and irritability, having inability to focus or impaired cognition, changes in appetite, such as eating too much or little, other symptoms like feeling negative, misunderstood, ashamed, worthless. All these add to the continuum of the number of symptoms that one would feel or experience when they are depressed. And so this is where we build it from. So when we are engaging with the community, we start from the understanding of what it is, because mental health by its nature is least understood in most of our communities, and therefore opening the conversation with what it feels like to be depressed always is a good entry point. The next slide really explores what is always at stake for the people and the family when depression is actually at the center of the problems we are dealing with in the household and in the people. One of the things that we've seen from experience and doing this work is that when a person is depressed, when a member of the family is depressed, and in this case, if you're looking at the woman in the household, in the African context, the woman is, for lack of a better word, such a social hub and such a survival hub for the family. And so when she is down with depression, there is a risk that she will not be able to work on the garden and be able to provide for the family food. And so food insecurity sets in. We also see that when depression sets in, there are effects like the lower economic productivity that comes in. So if they were engaging in any way to earn an income, if they are head of the household of their mother, they will not be able to do that. But we also see that in younger people where they suffer when they suffer from depression, then they are unable to attend school regularly, and that becomes a warning sign for them being at risk for dropping out. But we know that when depression is at large, then there are poor health outcomes in our community, like the morbidity of community, and to the worst extent, when depression is not managed, then we can even see cases of mortality that will be attributed to depression. It's associated with behaviors as well, such as increased alcohol use, but also the high risk sexual behavior becomes such an other area that sufferers of depression easily get caught into. And then at the very worst, suicide comes in or sets in as another dynamic. So this is what we look at for us to contextualize the level of damage that depression can do to the people, the family, and when you look at it to the bigger picture, the general nation. So I'll take you to the next slide. Yes. So what's Strong Minds intervention like? Our Strong Minds intervention is we respond to depression or intervene using an approach or a model called group interpersonal psychotherapy. This model is a WHO recognized model. The beauty about this model and why Strong Minds loved it is, number one, for the fact that we are able to scale the treatment of depression to more people in the group methodology, but above all, that we are able to deliver this model not depending on the expertise of highly qualified psychologists, but we are able to deliver it with the help of lay community workers and community-based counselors who are actually more available and accessible at the lowest level when you're looking at the context of community mental health. This model is evidence-based, and that's why we take it on for the reason that it's been tested, it's been found effective in helping to reduce the symptoms of depression. It is cost-effective, and with our experience now, we have tested out and seen that you can have a cost per patient amount up to $74 to help somebody recover from depression. It's culturally competent. We know that for many of us from the African setting, there is such a strong fiber within our culture to work things together in groups, and also that most of our cultures have a history where the place for passing on skills, for passing on knowledge, for passing on life values and skills was always in a group dynamic around a fireplace somewhere, and that totally fits in well with how this methodology works. It is accessible with a time-bound approach. We have sessions that are prescribed for this to happen, and through those sessions, we are able to help somebody walk the journey of recovery. It is scalable because right now we are doing this model not just for Uganda, but we are taking it beyond Uganda through partnerships to other countries that do not have a physical Strong Minds presence. In Kenya, in Ethiopia, and we are yet to take it also to Nigeria. And the expectation here is we are able to provide a scalable solution that would help us to deal with the epidemic levels of depression in Africa. It's replicable and self-sustaining. That is another strength of this model. So how does the model work? So this model is led and provided by lay counselors who lead the groups of about 8 to 12 people. And this is usually either in communities or in the schools where we are providing therapy. And the groups meet every week, and they meet for a period of about 6 to 10 weeks, depending on whether they are in community or in school. Now, if you've read the WHO guide, you will notice that the initial sessions were as many as 16, and we went learning and tapering these to where we are right now. And we still have found an interesting dynamic that even when we have done this in an evidence-based way, we still see people having excellent recovery rates when they go through the journey of therapy. In groups, members find a safe space to open up with peers about their worries and struggles. Clients learn how their depression is connected to the quality of their interpersonal relationships. They identify opportunities to create change and learn and practice effective interpersonal communication. And then lastly, within the way the model works, together, group members strategize solutions to their problems and learn coping mechanisms and identify support structures that can continue to lean on after therapy has ended. And this is the beauty of this model, that the skills and coping strategies that they are able to learn in the sessions are even applied beyond the time of therapy. And this comes in with the context of resilience, where we can strongly say that people from our evidence can go to periods of even 2 years when they have not had another experience of depression in their life, which speaks loudly about how they become resilient when they get therapy. For the benefit of the listeners and the people following me, when depression is being treated from an interpersonal perspective, there are key triggers that we focus on, and they become the basis for which we define strategies to support the person who is suffering from depression. Some of the key triggers, or the 4 main triggers that we work with, include sustained conflict, and this is usually happens with friends and families and loved ones, and this could be the trigger that could lead one person into depression. There is unresolved grief, and this comes a lot over the loss of a loved one or a relationship. And then there are role transitions, there are life changes, and these also come from all sorts of places, but the nominal or typical ones usually come from relationships like marriage, divorce, illness, motherhood, moving into a new home, changing town. All those contribute to that particular trigger. And then lastly, social isolation as a trigger also comes with a feeling of loneliness, being alone, misunderstood, bullied, and this also fits into the context of triggers. So when we get people for treatment, when we have assessed them and found them depressed using the Patient Health Questionnaire 9 tool, we are able to engage them through the use of IPT. And these are the areas that they will easily fall under for the triggers that led them to depression, or the triggers that contributed to their depression experience. So when Strong Minds did this work for since 2013, one of the things that we never stopped doing was to keep innovating. And I wanted to demonstrate to you how we've been working with the model over the years and how we have grown it, focusing on to how simpler it can be and how much more context we can put when we are thinking about scale. If you look at the bottom of the graph, you will see that we initially started a lot of our work with the staff-led work. It literally was down to how many more staff Strong Minds would hire to determine how many more clients we would treat. And we realized over time that that became quite expensive, that became quite difficult. It was not scalable in that nature. And so we took to the next step where we started piloting and learning from having volunteers and lay community health workers lead the therapy. And this is the journey we saw, that the numbers kept increasing. Then we got in and started working with NGO partners because we wanted to see the model go out so that more and more women and adolescents can receive the help that they can get if they're suffering from depression. And we've seen that number grow, and you can see the exponential growth that comes with it. When we took the adolescents on by tweaking the model to make it more suitable for young people, we still saw a growth in the numbers of clients that we were treating. And if you recall from my previous slides, I have mentioned that we have treated about 16,000 adolescents just with this model. We took the adult model and worked with a design called the human-centered design and worked with young people and adolescents to culture it and bring it to the tone and the context that is suitable for them. During the experience of COVID-19, we didn't only just close and run for safety, but at the heart of Strong Minds as an organization that prides itself in thinking big and acting fast, we thought, what is that innovation that will enable us to reach more depressed people, even in the context of lockdowns and restricted movements? And there we birthed a new approach called teletherapy, where we still provide this model, but on the platform of the telephone. And we are talking about your simplest, lower, your G2 or your lowest level phone in the village that your grandmother can hold and sit into a session. And what we did is we covered the cost that the grandmother or that woman would have to pay so that they could find it easy to join the group. And then finally, our biggest innovation has been opening the portals of working with government, working with the Ministry of Education and the Ministry of Health, creating room for this to be a mental health system strengthening process where we are looking at the health sector and seeing the place of talk therapy within the sector. Myself and Chris worked on a model where we delivered the community mental health, the first models of community mental health, which were strongly rolling out the medical aspects of the mental health care. And this looks to me like the last mile for mental health, especially at the community mental health level, where we are working with government to take to the communities first-line care that can be available not through the expertise of psychologists and highly trained, skilled staff, but through lay volunteers, like in the Ugandan context, community health workers like village health teams. I'm about to conclude. So these are some of the spillover effects that we've seen. One of them is that we have treated over the years 230,000 plus people who were suffering from depression. The beauty is that 80% of those actually come out of therapy depression-free, and many of them have depression symptoms significantly brought down to levels where they are free from depression. The beauty of this is that then when we have treated that one woman, the effect of that one woman helps us to connect and make value for about 920,000 people whose life is hinged around this woman. That when they are sick and when they are unwell and depressed, all these people, in a way, suffer the consequences and the effects of depression. And so these are some of the metrics as the years have gone to demonstrate how we got to the 230,000 clients that we've been able to treat. I would not take you a long time through that. This is how people come into therapy, pre-therapy, and this is post-therapy. When people are coming in and we assess them using the patient health questionnaire 9, we have found that the diversity of how many people are severe and moderately severe and those who are moderately depressed is high. But when we finish therapy and look at them or assess them at the post-therapy point, we see that up to 77% of them actually are depression-free. And guess what? 20% of these have mild depression. In other words, if they are able to work with the skills that they received in therapy, they are able to also become depression-free. I think that's it from me, Chris. Thank you very much.
Thank you very much indeed. Well, we've had two very powerful presentations, and more importantly, from my point of view, two very powerful models. Maybe Vincent, you could take the presentation down now. Thank you.
Thank you.
And what I can see is that there are a number of people who are interested in following up with you. So if Thandiwe or Zwiko, it doesn't matter which, and you, Vincent, if you could put into the chat your email address so people can easily contact you, that would be very helpful, I think. If you put that into the actual chat, not the Q&A, that would be very helpful. One of the people in the Q&A is saying that she's called Christina Mali, and she says her organization works in Goma, Eastern Congo, and she's very interested to see if we can integrate some of the approaches that you have been talking about as a panelist into their work with adolescent girls. And her organization is called Colors of Connection. Nice name. And so Christina, now that we are inviting Vincent and Thandiwe and so on to put in their email address, please take the email address and feel free to write to them directly by all means. That would be great. A question then for the panel, if I may. We have about 10 minutes left before we finish our session. A question, one of the things that I noticed from both presentations is the emphasis that you have given on what I would call livelihoods. In other words, the whole necessity for people to quite often feed themselves, or at least in the urban context, to make a little money so as to be able to feed themselves. So, and I wondered how important that had proved to be as you have developed your model, Thandiwe, for example, or Zwiko from Friendship Bench. Would you like to comment on that first, and then we'll invite Vincent?
Thank you for that question, Chris. Yeah, livelihoods have been important, and as Thandiwe was saying, as we're implementing our model, we discovered, number one, that it was primarily women that were sitting on the bench. And secondly, it was the root of some of these challenges were economical, especially based within our context with the economic challenges in Zimbabwe. So we decided to learn and innovate within that space and created this Seko Kubatana Tose group, which have a primary function of continuous healing, peer-led continuous healing, and also income generating support, which is directly linked to what the data that is coming out of the program. That the primary challenges are centered around economic challenges. And that has been important. And in terms of kind of evidence, as we were talking about in the beginning, in the last year, we began to try and understand better the impact of those, because implementation is one thing, but to learn in terms of the impact of those kind of income generating or livelihoods pieces of the work, because as you'd understand, the primary focus is mental health. But we know that this is necessary. But what is the impact of that necessity on groups? And we did a research last year on 2 of our districts, and we were trying to measure the net income of the as an outcome of the groups, as well as the dietary diversity. You know, what does it mean in terms of nutrition and food security for the groups? And some positive data was coming out of it, and we're rolling this nationally. So I think it is important for NGOs or organizations, as they implement even mental health programs, to be able to think around context and the idea of livelihoods as they implement, but the how also is important, and measuring the impact for continuity and sustainability of these small income generation projects. And if just one more piece around that is that we also developed like a framework around the income generating projects. So we are using the asset-based community development approach, which is kind of like gives control and ownership, because Friendship Bench is supposed to facilitate the starting of the groups, have the grandmother coordinate, but the ownership and framework around it is to make sure that the community members are identifying assets within their reach, skills within their reach. And some interesting projects have come out of these livelihoods projects, which we are, on the website through our quarterly impact reports for audience members to read about. Yeah, thank you.
Great. No, that's great. Thank you. I noticed, I'm going to come to you, Vincent, in 1 second. I noticed that Tanzo Mafosa says the spillover effects of interpersonal psychotherapy is very impressive. Indeed, mental health interventions need to impact the larger community positively. So there you go. So we are not alone in our thinking. And then Charmaine also says, thank you, Friendship Bench and Strong Minds, for sharing 2 very important community mental health innovations. Happy to see that the overlapping idea of community mental health support groups, an important aspect of continuous therapy. Thank you for that. And then we have Rukudzo. Now, Rukudzo, I think, is a special person for Friendship Bench. And it's lovely to see that you're with us, Rukudzo. Amazing presentations. Interesting to see how similar the ingredients for scaling task-shifted psychological interventions are across these 2 interventions. Important learning from those thinking about scaling to borrow these lessons towards eradication of depression. Very, very wise comments. Thank you very much indeed, Rukudzo. I wouldn't have expected less from you. Vincent, we come to you now for an answer to that question that I asked some time ago.
Yeah, thank you so much, Chris. You and I come from a background where we know that there is a mutual, or there is a mutual relationship or a vicious cycle between mental health and poverty. And in a way, that vicious cycle keeps appreciating or getting worse depending on which side is working out negatively for the person suffering from a mental health problem. If a person is severely ill, then their poverty levels will definitely go up because they are not working. But also, as the poverty levels go up, then it is likely that the symptoms that drive the mental illness that they are going through or experiencing then even become more severe. So there's a vicious cycle that keeps happening. And it's from that premise that it is difficult for us to look at our the effect of our work, looking only from the direction of how great it is able to stabilize and able to, how it enables people to recover from such a disabling illness as depression. But we also connect with the fact that when we are able to free one person from depression, we unlock so much that is in their ecosystem. And this is in their productivity, their ability to go, wake up in the morning and go to the garden and fend for the family, their ability to go and work if they have a job to do and come back with resources that enable to facilitate a family. And so within that is the context that we work as Strong Minds. And we have got a unique or special secondary indicator tool that enables us to consistently learn from the changes that are happening in our clients' life as far as their productivity is concerned, as far as their caregiving role to their children improves along the way. They are able to enrich, literally squeezed into loneliness, finally finds a social group and network to belong to and facilitate a peer-led or a peer interaction that enables them to remain long without any further symptoms of depression. So, Chris, at the heart of our work is the livelihoods aspect. And we feel that our contribution is to treat depression. And in our partnership with the Ministry of Health and the government of Uganda and in Zambia, our demonstration is that, look here, you have so many people, 20% of any population could be depressed in Africa. And if you have 20% of your significant population not working and disabled because of depression, I think the economic outcomes of that country will struggle. Thank you, Chris. That's all I can say.
Thank you. Thank you, Vincent. By the way, if you ever decide to work in another field, you could become a politician. It's great.
I would take that. I would take that seriously. Thank you very much.
I got my handkerchief. I'm going to start crying now because I have to let all of you guys go, and I'm just getting started. It's really a shame. There is one gentleman or one lady from Nigeria, a volunteer for Speak Up for Health, and they had a very nice question, which we will not be able to answer, but please take the email address and write to, it was for Vincent. So please write to Vincent with the question, and I know that he will take the trouble to answer it. It just remains for me, Tandiwe, to thank you very much for coming on and giving a lovely presentation. Zviko Morero, thank you so much indeed. It's been lovely having you, and incidentally re-meeting both of you since Oxford, which is absolutely wonderful. And Vincent, it's been wonderful to pick up our friendship from many years back, and also to know that from your CV that you are also still chairing Basic Needs Uganda, which is wonderful. So thank you so much indeed for being with us. Just to remind participants, we have a very nice session coming up after this one, which is all to do with the point of view of the youth, which of course is such an important part of the work in mental health. Once more, thank you so much. Absolutely beautiful session.
Thank you very much.
Take care. And
thank you so much, Chris. Thank you, Tandiwe. Thank you,
Vincent.
Nice meeting you all.
All righty.
All the best. Thank you.